I'm Peter Hudson, the Director of the Centre for Palliative Care. I'd like to formally acknowledge the traditional owners of this land, the Wurundjeri Nation, and pay respect to their elders and their families. Thank you very much for coming along this afternoon. We're really pleased with the interest. This is our last Centre for Palliative Care Hot Topic Forum for the year. If you mind just perhaps putting your hand up if you've been to one of these forums before. Okay, terrific. That's great. Welcome back. For those of you who are first timers, really the intent of these Hot Topic Forums is for the Centre for Palliative Care to provide an opportunity to highlight a contemporary palliative care issue that is of interest to those involved in palliative and or end-of-life care. So we've had previous forums have included end-of-life care pathways, sedation, and also euthanasia. But the topic of this afternoon's forum is spirituality, and I hope that nearly all of you in the audience would agree that spiritual care is core to good quality palliative care. However, there are a few contemporary issues, so for example, what does spiritual care really mean? I think there are some misunderstandings amongst healthcare professionals and also the community. Secondly, what's the optimal way to respond to a patient and family's needs associated with spiritual care? And thirdly, who should provide spiritual care? So should it be the domain of pastoral care workers or clergy, and or should it be the responsibility of the healthcare team as well? So I think these are key questions as we consider the notion of spiritual care in the context of palliative care. And we are very fortunate to have somebody present this afternoon who's a world leader on this topic to help answer some of these questions and provide some additional information about spiritual care. So pleased to have Dr. Bruce Rumbold with us on this occasion. Before I introduce Bruce, just a few notes. Bruce is going to leave some time at the end of his presentation for questions and comments and so forth. So one of the benefits of these forums is dialogue with you, the audience. You've taken time to be here today. We do want to hear your reflections, your comments and your queries. It's a great opportunity to discuss spiritual care this afternoon. So please note your questions. There'll be time at the end to ask them. Okay, so a little bit about Bruce. Bruce Rumbold is the Director of the Palliative Care Unit at Trobe University, where he has responsibilities for coordinating health promoting palliative care and spiritual palliative care academic programs alongside public health approaches to end-of-life care. He has postgraduate qualifications in physics, practical theology and health social science. He has not one, but 2 PhDs. He'll be probably annoyed that I've let you know about that. He is Foundation Professor of Pastoral Studies at Whitley College. He is co-editor of Oxford University Press's textbook of spirituality and healthcare. And I've been fortunate to have known Bruce and had him as a colleague for more than 15 years. And he's one of the pioneers of spirituality and public health in palliative care. He is a very humble person who is highly regarded by his peers. So I'm sure you'll be well informed with what he's got to convey this afternoon. Please make him feel most welcome.
Thank you, Peter, and thanks all of you. There are so many familiar faces in this room that I'm beginning to think I should just be skipping the slides and going straight into the discussion, but I will indulge myself a little and sort of go through at least some of this stuff. To give at least an illusion of order, that's the sort of stuff that I want to look at. And it'll go in and out of focus. Some of it will be reasonably hard data, some of it will be practice description, some of it will be frank and unabashed personal opinion. I leave it to you to work out really what the sort of the balance of things are, and that's partly what the discussion bit is about as well. So where are we? Well, that's what happens if you run spiritual as a key search term in PubMed from 2015 to 1980. Obviously, it's a back-to-front axis, so 2015 is this way, the odd 1,000 or so references, and it's beginning to vanish around 1980. you can track it back. It's an even smaller tale when you go back to around 1960. So what it says is that spirituality or spiritual has become an issue of interest and increasing interest within the healthcare literature. It doesn't show you the sorts of changes that are there, that it begins back on this tail with a lot of chaplaincy and palliative care and nursing material, and increasingly it's becoming mainstream medical-oriented material as well. So there's a change in content, the change in the people who are writing, a change in focus as things go on. And while it may be plateauing, so it's not perhaps strictly a hot topic, it is still a lively topic. To make the point that it's not a topic which is turned up in healthcare only, you can have a look at that, which is, now that's, I've flipped the axis this time, this is a proper axis, the right way around. And you'll see that if you do the same sort of search in the Library of Congress catalogue, you get a similar sort of shape, but it's 10 years earlier. In other words, what's happening in the healthcare literature is a response to a social event, a social phenomenon. That in actual fact, spirituality is becoming a growth topic, an area of interest in all sorts of ways from the 70s onward, and peaking in a similar sort of way. So healthcare is lagging or following on 10 years down the track on this sort of interest. What it reflects then, if you take a bigger picture, is a change in view, I suppose, or a change in understanding of spirituality and spiritual care. So if you look at traditional societies, which is usually a religiously oriented society, spirituality is a technique or a strategy within that society. Spirituality is about the disciplines that enable you to join up what's in your head with your heart. In other words, to turn your beliefs into practice, to become congruent in a particular way. And within various spiritual traditions or various religious traditions, there's a whole raft of spiritual paths or strategies or techniques there. With modernity, which is, I suppose, with the launch of technology, the mid-19th century onwards, particularly for a sociologist, we're starting to see spirituality being pushed back into the province of religion. Religion becomes an institution within many other social institutions. And within healthcare settings, as healthcare becomes a dominant discipline, the idea is you would make provision for those people who are unfortunate enough to have formal religious belief, but otherwise that's, you don't actually have to look after that particular. It's an add-on or an optional extra. So, but one of the features which obviously is associated with this surge in interest is the idea of spirituality, and it's largely referring to the resilience of the human spirit. Whereas in traditional understandings, you start with the idea that God exists and our job is to find out how to connect up. In today's understanding of spirituality, it's about us being spiritual beings and seeing where that might take us. And in that sense, within healthcare now, there would be an understanding, more or less, that there would be a spiritual care team, which probably would include a pastoral care worker or a religious practitioner who would support all patients in this activity of spiritual care or spirituality. So it leaves us with a whole series of contemporary questions about practicing spiritual care. Obviously the first of them is, should spiritual care be provided in healthcare systems? The debate about that's more or less disappeared. That was a hot topic 10 years ago. It isn't really much longer. It's more or less taken for granted that something ought to be done. But the debates still continue about who should provide it. There is an ongoing debate about how you might organise spiritual care. How can you respect the uniqueness of spirituality in terms of people's apprehension of it, and yet organise care? Where are the intersections into the current healthcare system? And you can pick, obviously, things like person-centred care. Palliative care has been a major route into healthcare in general. Cultural competence is another in which we might take religious and spiritual beliefs explicitly into account. And then as a further issue, given the fact that we already have some forms of spiritual care linked with chaplaincy-oriented systems, how does this model of spiritual care, which began in religious care, how does it link with the new health system models? Okay. Now, one of the beauties of spirituality is that there isn't an agreed definition. This drives researchers up the wall. I think it's actually the most powerful thing about spirituality, but that's something I'll get onto. However, there are attempts to define it. One of the definitions, and this is sort of like a scoping definition or description, comes out of a consensus conference from American Palliative Care Association 5 or 6 years ago. And this is one which is getting quoted around the traps quite a bit. And you can see how broad it is. It's making an assumption that spirituality has something to do with the essence of our being. That would be an area of debate for some people. And that is expressed through connectedness and to a whole range of experience, including the sacred, which again, we can debate. There's a more recent version out last year, and basically what that demonstrates that if you give an American definition to an international audience, they'll stuff it up even further. So here we are. It's a really complicated bit of stuff, but at best, I suppose you could say it's a scoping argument. This is the territory of spirituality. It doesn't take us all that much further in terms of how it might relate, however, with healthcare systems. To boil it down a little bit, I think Stephen Patterson's comment, little list is actually quite a nice one. Our needs for meaning-making, belonging, finding depth, pursuing some rather unspecified notion of the beyond or the transcendent. Patterson's got a later paper than this, which is called Spirituality, a thin, vague but useful concept, which in a sense spells that out a little bit more. But I'd add a couple of other comments. One of them is, from a social point of view, spirituality is about agency. It's about people taking some responsibilities or some initiative or some direction in their lives. In other words, it allows people to assert their identity, their commitments, their values, to celebrate their differences and their diversities, to resist expert control. And spirituality is used to resist the expertise of medicine and to resist the expertise of religion equally. In that sense, it is a counter movement. It is a movement against. In that sense, it is an insurgent tool. That's why it doesn't have a definition, because spirituality, to paraphrase Marshall McLuhan, is whatever you can get away with, in a certain extent. If you name it as spirituality and you can demonstrate that it matters to you, that's a social fact, and we begin to work with it. So the beauty of spirituality is its undefined nature, because you have to have a conversation about it. You can't make assumptions, or when you do make assumptions, you get it badly wrong. So it has to be conversed about. The other issue is, of course, once a definition is agreed upon, it's in the experts' hands. Definitions belong to experts. That's why, for example, you're not allowed to die of anything that isn't in ICD-10. Spirituality has that sort of flexibility and negotiability about it. And this is one of my assertions too, because some people would want to talk about spirituality as if it is a separate aspect of human experience. I don't see it as that way. I see it as an integrative aspect of our experience, that out of our physical and emotional and social experience grows the need to make sense of life, to find depth, to find meaning, to be connected. And in that sense, spiritual care and spiritual need emerge through these dimensions, not as a separable dimension that can be looked at elsewhere. Another area for debate, perhaps. So being a simple-minded person, that's basically what I'm looking for all the time if I'm going to be talking about spirituality. It's about identity, it's about connectedness, it's about meaning and purpose. Who am I? Who are we? What are we doing here? Are the key questions of spiritual exploration. And quite clearly, they turn up in a variety of ways, in a variety of circumstances. All of us, I would dare to suggest, have answers to these questions, but if I asked any one of you to elaborate them at the moment, I bet you couldn't do it. Neither can I. But we certainly discover when our answers are disrupted, when suddenly our life story takes on a different direction, we suddenly discover that in fact the old answers aren't working and new ones have to be negotiated. That's the territory of spiritual care. Now, in terms of whether there is evidence for this vague, thin, vague, useful concept, to stay with Patterson's description, allowing for the vagueness, there is a growing body of evidence around which suggests, yes, there are strong correlations between spirituality and health. There's an overall positive relationship between religious involvement and psychological well-being. There's a positive relationship between involvement and morbidity and mortality. Spiritual well-being helps people to cope. However, there's no evidence around that spiritual well-being is going to change things all that much at an organic level. It will change the way in which you deal with and cope, and perhaps live with, but it doesn't necessarily lengthen your life because you manage to make a bargain of some sort with some sort of higher power. When it looks at the literature that looks at spirituality or spiritual need in clinical outcomes also endorses the significance of taking spirituality seriously, that it matters to patients. That here we are, existential concerns often as prevalent as psychological and physical symptoms. Here's another bit of terminology. In Europe, people would much prefer to talk about existential need rather than spiritual need. That's because spiritual need is a peculiar English language phenomenon. It doesn't translate into almost any other language. So there's a problem in itself. When we talk about spirituality, we're indulging in a spot of English hegemony, and that creates problems. If you're going to go into German or Finnish, there are 2 or 3 different words you have to start to pick from. In Chinese, the word for spiritual is spiritual. There's also evidence, of course, around quality of life, that spirituality gives us the resources or puts us in touch with the resources we may need to live better, to live well, to live constructively with whatever it is that life brings to us. When we look at the literature about responding to spiritual need, it starts to get ambiguous. Part of it is due to some rather strange assumptions that are often made in the research design. For example, there's a sort of a seaweed effect, I'd call it. You know how that sort of business is? You've got all these people on an island off Japan who live long and healthy lives, and you've got to find some reason for it, and it's probably because they all eat seaweed. And so the seaweed therapies begin. A similar sort of thing happens in a lot of the spirituality thinking in healthcare. People who profess religious or spiritual beliefs often have reduced morbidity and increased mortality. So what distinguishes them? Well, usually they pray, don't they? So let's see if we could actually administer prayer as an intervention to change people's health status. You see how woolly the thinking is. There's a lot of difference between having your life embedded in a particular way, leaving aside all the questions about social determinants, and thinking, well, okay, we can sort of pick that and turn it into a technique that might actually change things. And surprisingly, by and large, it doesn't work very well. One of the best examples, the loveliest example, is the Cochrane review of intercessory prayer at a distance. If you're looking for a bit of a laugh, I suggest you see if you dial it up. But the idea is, because if you want to do randomised controlled trials on spirituality, you need to find a spiritual intervention that people don't recognise they're having. It's a little bit difficult to arrange in most of the ways in which we offer spiritual care, but intercessory prayer at a distance works beautifully. So you divide a patient cohort up into 2 groups, you pray assiduously for one half, and you as assiduously neglect the other half, and you look for differences. This is a remarkably stupid idea, but it has achieved funding for a number of trials have achieved funding for health reasons. I mean, it's just doesn't be. I won't even start on what I think's wrong with it. But one of the best examples of what might be wrong with it is a trial which took place after the Cochrane review, where they had 3 groups: the unconsciously prayed for group, the unconsciously not prayed for group, and the consciously prayed for group. And they did worst. Because when you discover that people are actually praying for you, you know you're in deep trouble. The There are, of course, other things like that. I mean, there's increasing amount of data about meditation being an effective intervention. I'd argue that in actual fact prayer would be too if we did it in the same sort of way. If you actually taught people to do things, because it's about the business of establishing agency, giving people tools for dealing with their situation. So because we are in a prayer-oriented society like America, you tend to go for a meditation thing, which is a different tradition. You could do the same thing, as I said, I think, with prayer. Another bit of evidence, and this gets even vaguer, doesn't it? When you look at NICE, National Institute for Clinical Excellence, and their core spiritual care strategies, this is the sort of stuff you have. Which is pure and simple, person-centred care, is it not? Good care. Nothing particularly spiritual about it beyond the word spiritual getting put in there. And I guess attention to people's beliefs and philosophy of life. And that sort of stuff gets pushed forward further into the European Association of Palliative Care core competencies. And here they are, a blanket statement that palliative care professionals should be able to be reflective about their own lives, integrate the whole range of needs into the care plan, provide opportunities for reflection, be conscious of the boundaries. Again, good common sense and a series of recommendations which begs a whole series of questions about how you might actually do it within a contemporary healthcare system. So, coming back to my sort of assertion, I suppose, should we provide spiritual care? My answer would be yes, but you need to understand that healthcare professionals don't have a mandate to provide spiritual care, but it's really important to inquire about it. If you come as a professional and ask me about whether I would like you to offer me spiritual care, my answer is probably going to be no. I'm reasonably sorted, and I guess I would much sooner rely on my friends of 50 and 60 years than somebody who's a blow-in, although I might like to have a conversation with you occasionally. But in that sense, it's, as in many circumstances, a professional is usually a poor substitute for a lifelong social network of people who live with you and love you. Many people don't have that, I know, although here I go over yet another horizon. We often forget that the people who appear lonely often have a huge network of friends, they just happen to be dead. That's okay. There are many dead people who are very lively in our lives. So the spiritual care task, as we start to try to put it into the healthcare system, begins to, I think, present issues like this. It's a multidisciplinary task. If it's about identity and connection and meaning and purpose, one of the real problems with the spiritual care literature is the psychologists try to cherry-pick identity, the sociologists try to cherry-pick connectedness, and the philosophers, theologians try to cherry-pick meaning-making. You actually need the whole thing tied together. And in that sense, spiritual care is a multidisciplinary, it is a team activity, not just an individual's bit of work. I think I'd also want to say that I think that within the contemporary healthcare system, all carers should have the capacity to contribute in some way to spiritual screening. And I'll say a little bit more about that in a moment. And obviously, it's a good thing if a healthcare team can have access to skilled assessment, on-site or somewhere else in the neighbourhood. A good thing. How you might do that, I'm not quite sure. There is a range of formal assessment tools. Most of them are pretty useless in terms of clinical use, unless you really want to run a person through a 100-item inventory on a regular basis. More compromising to health status than anything else. And a lot of them too, I might add, reflect a very narrow religious cognitive understanding of spirituality, where a lot of the neuroscience arguments now are that spirituality is essentially to do with our limbic system, and religious belief is mediated through the neocortex, etc. Okay. But nevertheless, we've got this range of materials around. Screening, however, is more down to the nitty-gritty, I think, and that's really the sort of stuff in which we, I think, should find ourselves involved. And here's a quick whip through 4 strategies. First of all, my preference, what lifts your spirits? Simple. And it can start a conversation in all sorts of different directions. It isn't something which requires the sort of explanation. If I ask you, where are you with your spirituality? I think I get a rather different response than with a question like that. So, in a sense, as a practitioner, insofar as I still am, I'm more or less happy to live pretty much with that. But if you want to get more organised, one of the strategies is a formal inquiry, and this is the Christina Pahalski's Spiritual History, which I think is being slowly wangled through to become a requirement of history taking and admission in American hospitals at the present moment. And that's the FICA method, and that's basically asking people, do you have a faith or beliefs that matter to you? Do you have a faith or beliefs? Do they matter to you? Are they important? Do they provide you with a community to support you? And importantly, on the basis of this, what action, if any, would you like us to take? In other words, do you want us to include this in the sort of care we offer to you? So immediately there's a negotiation set up. There's an inquiry, and from there, a negotiation about how people's values and beliefs might become part of the system. And there are similar schemes like spirit and hope. Again, one of the problems with it is it's a very cognitive sort of framework. If you ascribe to a religious framework, well, you probably can give answers to what are your beliefs. A lot of us would struggle to articulate them, and in that sense, we probably need other forms of exploration. But this is a good one to at least set up a conversation or an inquiry, and hopefully to make some appropriate referrals as people are admitted to a larger institution. There are other facilitated exploration strategies like this one, which came out of Northwest Metropolitan Palliative Care Consortium, well, City Mission, likely. And there you have a conversation starter. It actually needs more blank balloons than it got, but that's probably something in retrospect. Okay. And then finally, the sort of stuff which I prefer to look at is, again, this relational web idea, which is picking up the idea of connectedness and the way in which we invest experience and meaning into connections. This comes from an African colleague, Emmanuel Lati, who talks about spirituality involving this web of relationships. And you can see that within them you have this whole series of places and things, aspects of self, relationships, communities, systems of thought, culture, ideas. And his suggestion is that, in fact, this standard matrix or standard grid, we inhabit each of us uniquely. And because when you think about it, the combination of things you can put into there, it's like an email address. They're very simple forms, but every one of us is uniquely identified in cyberspace by our own particular version. Spirituality in that sense is like that. And so here's a mode of inquiry that you can undertake, and to do it reasonably unobtrusively. The idea behind it is that most of us are held in place reasonably robustly when things are going well, but when things get tough, the strands start to break, and the question becomes, so how do you start to repair? What remains? What can you still rely on? What can you do about what has gone? And so in that sense, spiritual need is understood by biographical or disruption. Something that really matters in our story has been taken away from us or made inaccessible to us. And clearly, the ideas are based around a whole of life. It's not just an end of life type of experience. And I suppose maybe that little comment at the bottom, the reminder, insofar as a lot of our discussions of spirituality are about end of life, it's actually too late to be discussing spirituality at end of life, to a large degree. If you intend to rely on something at the end of your life, it's not a bad idea to do something about it before. So you can map the stuff out, or as on the Palliative Care system, you can got a pane in which you can enter a whole series of observations about what you see, about what matters to this person. And from there you can start to generate patterns of understanding, and you can respond in terms of what I would see as standard sorts of strategies around addressing the settings, addressing the stories, looking at the systems of belief. So a fundamental thing, this is a public health perspective, isn't it? You start off by a safe environment. Where does a person feel safe? How can you connect somebody to that environment? There's a sense in which if you can do that, you don't have to do an awful lot of talking necessarily. Safety, connection matters. And there are all sorts of ways of doing that through symbols, through activities. Stories, similarly, are often a way in which we rework our understanding of ourselves and the world. And a good listener, a skilled listener, is able to hear both the stories that are told and the subtext which are not addressed. Why is it that I hear only these sorts of stories, and what happened to these stories in your life becomes the question. You know, it's a typical grief counselling one about after you've heard 2 hours of what you really miss about a person, you ask the question about, so what don't you miss? You get a lot of interesting feedback then. So in that sense, listening and inquiring is there. And then, of course, there are the systems of belief which are about family rituals, family beliefs, and perhaps formal religious practice. And that's the sort of stuff where we definitely do need the outside of the external expert to come in to be part of the care system there. So spiritual care doesn't start necessarily with the systems of belief, but it should incorporate them as it is. Final quick flurry, if I may. How does this stuff then, or how might this stuff begin to look or get into a healthcare system? Well, a standard healthcare strategy is to ask, the policy is to ask the question, what do you have to do? Everybody, most people, some people, a few people. And how do you allocate your resources across it? And there are versions of that sort of 4-level spiritual care thing. I think this is probably my version of a bit of work originally done in Scotland and modified through Spiritual Health Victoria. But I'll take responsibility for the worst features of it anyhow. But then that first, what should we provide for everybody as a foundation for spiritual care? The simple answer is person-centred care. Treating people as people, because spiritual care begins in our fundamental humanity and being able to engage in that sort of way. So in that sense, screening is unobtrusive. It's looking for things which might be going awry and knowing who you might actually ask about or refer people to about that. Level 2 is beginning to introduce spiritual care a little bit more explicitly. And so it might include people who have the capacities to inquire directly about spiritual concerns and not be thrown by the answers that they get. Because it's one of the real dilemmas of spiritual care is, who knows? Ask the question. You need to be able to cope with the answers. Level 3 is getting into the area more of training and people who have spiritual care, at least as part of their job specification and description, capable of working with people in terms of their decision making and competency in, as I said, recording and being stewards of information. And then finally the complex stuff, which is where your experts reside. And these are people who have the capacity to work with complex need, but usually will also be a resource for the other levels. So that means it's the typical healthcare model, isn't it? In that sense, you have the people who are consultants insofar as they provide treatments, but they also consult, they supervise, they train through the system. So that's a suggestion that if spiritual care is going to find a place within a healthcare system, it has to adopt a shape something like this, not necessarily this one, but it has to be organised in a way which is recognisable and which at least correlates with the sorts of activities that other professionals are undertaking. And that's got implications. It's got implications for chaplaincy practice, which are already taking place. That chaplains are beginning to move from what was a religious orientation to a whole of hospital orientation. They're beginning to take on more coordination tasks, beginning to look at accountability within the system as well as outside the system, beginning to understand that there are multiple knowledges, not just theological or religious knowledge that's required. And nevertheless, being able to not just comply but also subvert, in other words, to call the system as well as to work within it. NICE also puts up a series of comments about how supportive care that includes spiritual care needs to be addressed within a whole range of healthcare disciplines. Slightly nasty comment, isn't it, that first one? Healthcare professionals have limited abilities in detecting psychosocial needs, but they can be developed through training. That's not me, it's the National Institute for Clinical Excellence, okay? I think, in a sense, what they're talking about is not so much personal skills, but I think it has to do with an orientation. That as clinicians, you're trained to solve problems, to see a problem, to go to it. Spiritual care is actually about creating space and often stepping back and holding. It's a very different sort of response. And in that sense, it requires conscious and reflective practice. So 3 questions. These are probably my questions more than yours. I've been sort of hanging around spirituality for the odd, what is it, 1980, it's 25 years, 35 years, strike, half my life. I'm still not necessarily persuaded that spirituality is the best language to use. What I'm interested in, I'm very much convinced that what spirituality is trying to get at is essential for the healthcare system and for reforming the healthcare system. But whether it's the best way of getting in or I don't know. And one of the things that I find really interesting is that emerging conversation around compassion, which is a much broader or more easily accessed term than spirituality. But it has its own problems too, particularly McDonaldisation. Because increasingly the idea of compassion is have a nice day, rather than anything which actually would meet the name. But it's really interesting, I find, the way in which a lot of our healthcare guidelines are increasingly imbued with spirituality, but not necessarily using that language. And a sort of a halfway example would be the guidelines for clinical guidance for adults, the suffering of adults with cancer. It's not quite the right title, is it? But there, that was actually started off as a spirituality and suffering guideline, and the spirituality bit has disappeared, and yet is actually embedded in clinical practice within the guideline. Another one, this is actually very badly expressed, but never mind. One of the troubles with being a healthcare practitioner is you have to spend half your life being better than you actually are, which is really painful and leads to a lot of bad behaviour out of hours in forms of compensation. But you know, there's a sense in which healthcare is supposed to demonstrate all the values and virtues which society is largely given up on. Like you've got to have equality of access, you've got to have respect at all times, you've got to have compassion, you've got to have warmth. I mean, come on. This is really difficult stuff. And one of the real risks of even spiritual care is that we're going to sort of try to lump it onto the healthcare system and say, well, you will provide spiritual care. I don't think this health system should provide spiritual care. I think it should make it accessible. I think that it is inevitable, in my view, that healthcare needs to be skilled and well-versed in spiritual care, because it's usually in healthcare settings that people's biographies become disrupted. That's where you get the bad news. That's where you're told that the cancer's come back. That's where you're told, etc., etc. That's where you need to have somebody who can actually hear it, register it, and be able to point you to somebody where you live, not just in the institution. So we need care in the community. And that's, I think, also where I have some problems around the idea of compassion. Why should healthcare be compassionate when nobody else in this bloody society is compassionate? Well, sorry, I am a grumpy old man, you understand, but you know, it is really quite ludicrous. And even within the institution, you have these enormous clashes of the compassionate clinicians and the administrators who are trying to drive, you know, trying to interface between a shrinking healthcare budget and a whole series of deliveries which are impossible. It's a very difficult situation. Final comment about that, I think religion still has got something going to it. One of the things that strikes me about healthcare spirituality is how sentimental it is, by and large. Everybody seems to act as if spirituality is a good thing. Let me tell you, spirituality can be demonic, it can be disruptive, it can be dangerous, it can be cruel. We don't have the capacity to distinguish within the healthcare system at the present moment, and we need it. And that's an area where at least some religious insight might give us some faith. The other thing is that, again, within healthcare, a lot of the spirituality stuff is going back to belief. By and large, religion will tell us that what matters more than belief is right practice. One or two beliefs that you put into action are worth much more than a head full of doctrine and a life that doesn't match any of it. So those are some of my sorts of ongoing thoughts. And now I'll stop and you can tell me what I should have said in this last half hour or so.
Please thank Bruce. We've got about 15 minutes, and as I said at the start, the benefit of these forums is an opportunity to raise questions and comments and so forth. So please, we want to hear from you, and if you want to clarify anything with Bruce, now's your opportunity. It's just a matter of courtesy, if you wouldn't mind just introducing yourself before you raise your question or comment. There is a mic coming down. Yeah.
Alfie's going to get a lot of really good exercise. Next question has to come from the back.
Hello, Bruce. Irene Winston. How do we guard against every member of the multidisciplinary team wanting those deep and meaningful conversations which are so satisfying?
Well, the first thing is not everybody wants those conversations. Maybe in palliative care where you get a lot of warm and fuzzy people, but in healthcare in general, a lot of people don't want them. And I suppose ultimately it comes down to a team where there's enough honesty to be able to say, well, this is the stuff you do well, this is the stuff that I think I do well, how do we work together in this? I mean, it's negotiated.
Sue Hookie, my question is, you were talking about screening and how we all need to be potentially generalists. Yeah. Where in Victorian curriculums are our budding health professionals learning about screening? Is it actually being taught in any curriculums to do spiritual screening across health professionals?
What an excellent question. I can't speak for nursing curriculum, although I think there is, in some nursing schools there is some. Obviously I teach it within a postgraduate sort of framework. Oh, and a few other undergraduate classes where I sort of do hit-run bits of stuff. But no, it actually isn't there. And that's a very lively issue too, because it's one of the Australian New Zealand Deans of Medical Schools have listed it as a skill which should be there within medical training. Doubt that it is. So maybe all of you need to start asking that question elsewhere within professional development context too.
Rosemary Hudson. Bruce, thank you very much for your presentation. I'd like to hear your ideas about spiritual care plans and the documenting of spiritual care plans in a way that can be reviewed and evaluated. And if you believe in spiritual care plans, whose responsibility is it to develop and document and evaluate them?
So it felt like a climate change question, Rosalie. No. Yeah, look, I think that I'm not entirely, I'm ambivalent about whether you have a separate spiritual care plan or a designated bit. I think that spiritual care should be integrated with the whole of the care plan. In other words, that we pay attention to connection and meaning and identity, and we do that in terms of whatever else is being done to a person. Because I think, in actual fact, we often are not aware of that an intervention we may administer to one person is taken in its stride, and the same intervention for another person becomes incredibly disruptive and distressing. And in that sense, spiritual care is knowing the difference. And I suppose why I'm interested in that relational web model, where everybody puts together the bits and pieces of the gossip that they pick up, is that you can, from it, perhaps a pastoral care person or a chaplain spiritual care person can develop strategies, but everybody can see how the strategies come out of the bits and pieces of the information that they've provided. So it doesn't come out of the blue, it comes from, it's developed on the basis of what a team has put together and what is transparently available on the page in the Palliative Care system or whatever it might be. That's a short answer anyhow.
Just while people are thinking of questions and comments, Bruce, just you spoke very candidly about your notions about generalist healthcare providers' responsibility with regard to spiritual care. I'm just wondering if perhaps if you could comment or elaborate in a bit more detail about what you perceive is specialist palliative care's role in spiritual care.
That's an interesting question, Peter, because do I need to be careful what I say here? Probably not. I think one of the real dilemmas of specialist palliative care is that it's become so end stage that in actual fact it makes it really difficult to do anything useful in spiritual care. So I would really like to see specialist palliative care programs having specialist spiritual care providers, but making them available early in the illness course so that people can work on these issues. And in a sense, when symptoms become uncontrollable or florid or difficult, in actual fact, you've already got the basis there. So, I mean, my problem with specialist palliative care is the way we seem to have it, it's either on or off. I know there are many glorious exceptions, particularly in rural situations, where you actually can get that in and out, that interflow between palliative care and ongoing treatment. But the more we organise palliative care, I think the harder we've made it for ourselves. And so I would really like to see a lot of spiritual care. Yeah, I'll go further. I would like to see specialist spiritual care embedded in communities, and in that sense it's available to a whole range of healthcare and welfare organisations. That's not to say that there can't be specialists in hospitals or whatever as well, but in a sense the one-off interventions you do in an acute care institution are a bit problematic if there isn't some sort of flow and a follow-through into the wider community life. I thought that'd get you going, David.
Thanks, Bruce. David Dawes. The community one is, when I try and make a referral from Peter Mac into the community, who am I able to refer to who don't want to have a payback or a benefit of bum sitting on pews? Mm. And how do we train and educate and get a core group in the community who can be referred to?
Yep. The dilemma is exactly as you describe it, is it not? I agree. I mean, it's a public health issue too, isn't it, in general, about how do you actually get people mobilised around particular concerns. And I don't think there can be a single straight answer. In some communities, we actually do have some good ecumenical or interfaith groups who actually get together and they seek training and they can do a good job. They're a referral source. There are other areas where church groups have got together and would like to be a referral source, and it would be irresponsible of you to refer them, anybody, to that particular mob of people. I'm not sure how we do this quality control stuff. Maybe this is Spiritual Health Victoria's task. I mean, they actually have started to do some work. Christine has started to do some work on that in small ways. But to my mind, if we don't get this stuff right, I don't know where we go with spiritual care within the acute care institution. So in case you didn't get that, it was I don't know.
Yeah.
Christine Hennequin from Spiritual Health Victoria. We don't know either. The challenge is the specialist spiritual care, the person-centred care, spiritual care integrated in healthcare. It's all there in the, it's not a policy, but it's all there in the documents.
Yep.
But it's trying to get resourcing, trying to get projects up to actually demonstrate its value. We've tried to get a couple of regional positions in community, and it's really difficult. It's really, you know, we've been able to get regional health service positions, one, or working parties, but it's very difficult to get the support. It is a public health issue, and to get it instigated in the community.
And that becomes a political priority because at the present moment 95% or 5% of our health budget is preventive care. 95% is the ambulance at the bottom of the cliff. And in that sense, that's why, in a sense, in a worldwide stage, if we do not reorient our systems, we're just in really deep doo-doo.
Annie Forrest. Bruce, was it Harriet Mowat from Scotland who was out a couple of years ago?
Allegedly Scottish, anyhow.
Right. She had a trial or a project or something that sounded pretty impressive. And again, it's what Christine's saying, it sort of came down to resources. But they had a pastoral practitioner -- chaplain -- spiritual counsellor placed in a few GP practices. And one of the reasons she was sharing with us how it worked was that the GPs were pressed for time. They couldn't sit and talk about the whole person. They were just dealing with the medical issue. And the person would leave and feel as though they hadn't been listened to. And so they were offered an opportunity to go and speak further to this person. And in providing spiritual care, a big aspect of it is allowing, as Bruce said, allowing that space for that person to find out for themselves what's going on for themselves, and to feel respected and to feel heard.
So it's one of many local sorts of solutions, I guess, which can be looked for.
This will need to be the last question or comment.
So Hookie, there's a lot of funding going into advanced care planning, and the big push is to take advanced care planning out of hospitals and into primary care, so that's a great segue. We also have a lot of experience with chaplains in schools, and I can see that there's possibly some cross-fertilisation or some possibilities with what you're talking about, because chronic disease is the time we need to start talking, diagnosis is when we need to start introducing advanced care planning and encouraging people to think about those existential or spiritual questions. And in primary care is exactly the right place to be doing that. So if Spiritual Health Victoria could work in that area, that would be fantastic. Thank you.
Thank you. It's a very useful comment to finish on, I think. And I suppose just to make one final comment would be that we often can feel pretty run down or weighed down with the burden of it all when we look at it from within the healthcare system. But the reality is there's a lot of good stuff happening out there in the community that we never get to hear about. And in that sense, it is more a matter of saying, it's not so much a matter of saying we have all these problems that need to be solved. I think we need to start to look for the assets that are there out in the world around us. And for example, colleagues in New South Wales have been doing some wonderful stuff around social networks and support of people who are dying, and looking at the way in which groups of ordinary people can gather around and look after each other. And in fact, one of their biggest problems is accessing the health care that they need without having the healthcare practitioners come in and take over. So in that sense, we have to find ways of rethinking our engagement with community, but recognise that the assets are out there in many ways.
On behalf of us all, Bruce, thank you very much for sharing your extensive wisdom on this important topic. It's greatly appreciated. Thank you very much.